surgical approaches to the forearm. And as always, this is a very interactive talk. And we have Jessica and Travis and Joe Larkin on the line. Exciting. Joe, are you going to answer some questions for me today? I've got some especially difficult questions to run up the tree for you.
Well, I'm pulling Google up on my other screen, so swing
Okay,
away.
yeah. All right, that's good. That's what the residents are doing too. Funny, huh? You're figuring this out. Actually, I think probably Camille can tell you by now that doesn't get you far. It'll get you and probably actually, it actually won't get you far at all. It probably takes you backwards in my clinic is searching for Google. Camille is doing a great job in her rotation. Camille, what is the key? One key to success on the Dorf rotation? There you go. Study a lot all the time. Don't get a question wrong twice. That's, I think, the last part's the most, well, they're probably all linked together, right? Because I will ask the same question again and again and again. If you get it wrong more than once, it doesn't make you too happy. That's what this talk is all about, because there's a lot of repetition in this talk too. So we are extending our knowledge. We started in the shoulder, then we went down to the elbow, and now we are down in the forearm. And as I told you last time, the forearm is really just an extension of the elbow. So don't get confused in the forearm. It's not that hard. This is so funny with these guys who've got you can see their template in the back that they've got. It's hysterical. I don't know where that is. I'm not going to say. It'll be bad. It's actually simpler. The forearm is actually pretty easy. And we're not going to go into a crazy amount of anatomy in the forearm. This is kind of just basic extending the elbow through the forearm. Once we get to the wrist and hand, we have plenty of opportunity to add a lot of that anatomy. So this is really this is kind of more big picture stuff. So the forearm is really just muscles that move the hand and the fingers. Okay, so movement of the wrist, fingers, thumb, as well as pronation and supination of the forearm. So let's go back up to the elbow. This is where this is all going to start, right? Because that's where all of our flexors and extenders are coming from. Okay, so we have the 5 muscles that originate from the medial epicondyle. Okay, let's start with those. Grace, you want to give us those 5? Yeah. Radialis, yep, FCR. Next, right down the middle. Palmaris, yep. Then, yeah, that's it. FD. S, yeah, FDSs.
And it's the flex.
FCU, right? So they're just going across. And then we've got our 5 coming from the lateral epicondyle. Volunteers for the lateral epicondyle. Nicole, I know you've got this.
Flexor carpi radialis brevis.
Wait a second. What side of the arm are we on? No. Which side of the arm? What are they? All these words start with.
Oh, sorry, extensor.
Okay, extensor.
Yes. Extensor carpi radialis brevis.
ECRB. Okay.
Extensor digitorum.
Okay. EDC.
Extensor carpi.
Okay. ECU. No, not really. Okay. Funny one around the corner. Camille's got it in there. Yep, nice. One more. It's kind of a weird one. Camille, you know it? EDQ, yeah. So Anconeus, ECU, EDQ. And EDQ is a weird one, right? It's like this tiny little thing that goes all the way down to the small finger, but it starts way up there. Then EDC and ECRB, okay? So that's our big picture where we're starting at. That's a base. Now, this is easy. Remember how hard these questions were in the very beginning? You guys didn't even have a clue. So for primary nerves crossing the elbow. Jessica, can you pipe in, our regional expert?
I am driving, so I apologize.
Oh, no, you don't. If you're driving, I do not want to be responsible for you crashing your car. I know this question is too hard for Travis.
I'm also driving and unavailable to answer any questions moving forward.
No, you're just unavailable to answer questions. All right, let's keep it in the room. 4 nerves cross the elbow. Camille. Yep, it's the distal extension musculocutaneous, which is lateral antebrachiocutaneous, which we say LABC, which we find in what surgery all the time? Travis, what surgery do we find LABC in? That's what I thought. There's only one surgery we really find it. I don't know if you've seen one. Distal biceps repair, okay? In general, what's their function? Radial nerve, what's it do? Big picture. I'm seeing lots of visuals. Radial side of the forearm does what? Extends fingers, extends wrist, right? How about median nerve? Flexes the wrist, flexes the fingers. How about the ulnar nerve? Hand intrinsics, right? You guys would not have gotten that right on day one. Hand intrinsics are so critically important. Like the ulnar nerve, you screw that thing up, man, you are in a world of hurt. Hand intrinsics, ulnar nerve. And LABC, what's its primary function? Yeah, sensation. So it's sensation lateral forearm, right? That should not say extension. That should say sensation. I edited this morning in a seriously jet lag state, so sorry about that. Okay, which nerves innervate these muscles? Pronator teres. What is that going to be? Median nerve. FCR. Oops. Palmaris. FDS. Okay, so when we're talking about flexors, we're almost always talking about median nerve, except for the next one, ulnar nerve. So we have seen the ulnar nerve after it comes through the cubital tunnel. What's the first thing it enters? No.
Sorry.
Right after it goes through cubital tunnel, next thing it goes into the ulnar nerve. It dives right into this muscle belly, which is written on that screen. FCU goes through cubital tunnel and goes right into FCU. So you know it's got to innervate it, right? So it's sitting right there. All right. What about the lateral side? Anconeus. Radial nerve, ECU, PIN, EDQ, okay, EDC, okay, ECRB. Yeah, radial and PIN. There's some variety in there. Okay, but we normally think of it being radial nerve innervated. Okay. All right, now we've gone through flexors and extensors. Simple so far, right? Review. Pronation and supination. What are the muscles? What are the two muscles that that pronate the forearm? Pronator teres, pronator quadratus. Okay, good. And what's going to be the next question? Well, wait a sec. Oh, oh well, all right. That wasn't even what I thought was going to be the next question. Typically, the next question is what nerve innervates these two muscles. Where are they though? This is interesting, right? What's interesting about the pronator teres and pronator quadratus? They're like opposites of each other, right? One is very proximal and very superficial, and the other one is super distal and deep, right? So pronator is that first one. It's coming right off the medial epicondyle and going across all the way across the forearm. Why do we do that? Why do you have one that's really proximal and one that's really distal? Sure. Well, or why not put one in the middle? Right. So you got to have the most motion proximally and distally. So that's where you're going to try to pull from. Imagine if you're trying to, if you were the muscle and you're in there in the forearm, you're trying to rotate something over your head. You can't really do that very well. If that thing is you're right at that sort of central point of rotation. But if you're a long ways away from that point of rotation, that thing is swinging around the corner, then you have the leverage on it to move it. So you've got one really proximal and one really distal, one really superficial and one really deep. Superficial gives you leverage to pull something way around the corner. Deep gives you power, right? That deep stuff, it's close in. All right. So it's all physics. Something that traverses a long distance over a long ways gives you a long range of motion. Something that's short little fat muscles. Those give you the power. Does that make sense? So there's that. Look how different they are. One's really superficial and proximal, and one's really deep and distal. All right, now the question. What nerve innervates those two muscles? Median-ish. So median nerve proper for both of them. Joe. I'm just kidding, Joe. That is not a nice question. AIN, anterior interosseous nerve, right? So that AIN is the most distal motor, well, not the most distal motor branch, but it is a distal motor branch of the median nerve, right? Who here has seen a person with an AIN palsy? Yeah, you sure did. So Camille, we saw a little girl who came into our clinic who had an elbow dislocation and had AIN palsy. So we're going to get to learn how to check for that AIN palsy and AIN. All right, what muscles supinate the forearm? Supinator and biceps, right? Biceps, a little bit of a trick question, but that's it. Those are the two. That's a terrible picture of the biceps. I don't know where I got that from. Supinator's pretty good. I actually like this picture. I don't like that these pictures are opposite and flipped upside down. And anyway, there's the biceps. We all know that it's going down and attaching to the biceps tuberosity down on the radius, and it's rotating the forearm. Traveling a long way, so it's got a lot of motion, right? So it can move things a long ways. Not as strong, but it can move things a long ways. And then supinator, there it is. I'm going to show you another picture of that. And now, is it Halloween today? Holy moly, then that's good. We have a mysterious muscle in the forearm question. What is the most mysterious muscle in the forearm? Supinator? I think it's good. I agree. I think it's the supinator too, because the supinator, like, where does that thing start and where does it end? And how does that thing supinate the forearm? It's weird, right? But think about it, it's kind of like pronator quadratus distally, but it's on the backside of the forearm. So pronator quadratus is deep and right on the muscle or right on the bone. The whole thing just wraps around it. Supinator is kind of the same way, but it's proximal, but it's in this kind of vague area back in the back of the elbow or the back of the proximal forearm. So it is a funny one. I think Anconeus is even more mysterious, but that's because people don't even know how to say it. So there it is. That's the supinator right there. Do you see where it starts here? And then it literally wraps all the way around and attaches up here. Literally goes all the way around it. Why is that? What is so critical? I mean, there's a lot of critical things about this. Is supination of the forearm the most critical thing about this as far as why is this muscle so important? What travels through the supinator that is so critical to the rest of the function of the forearm? PIN, right? Radial nerve, it's branches and it's got two branches and those branches go down and the PIN. And I'm going to show you a wicked cool picture of the PIN in just a minute. Nerves that innervate the two muscles that supinate the forearm. Okay, PIN for supinator, right? And then what else? Musculocutaneous nerve proximally. Biceps, musculocutaneous, supinator, PIN, right? How are we doing? Oh, we're moving fast. All right, now let's think about flexors. What do you think? FDS, FCU, FCR, pronator quadratus. Where are they all going to start? This is review. Where are all these flexors starting? The what? Lateral epicondyle. Medial epicondyle. We had three in unison, lateral epicondyle. We were on the back of the forearm. Everyone stayed on the back of the forearm. They're going to rise on the medial epicondyle, right? So the other key to doing well in the Dorf rotation is maintaining your composure, especially in the OR, taking a deep breath, thinking about like really basic stuff. Start with the basics and then work your way out from there. When I get confused in the OR and I don't know what to do, or we're doing a revision ulnar nerve decompression, and we can't figure out where we are. First thing we do is go back to something we know. Okay, so somebody's been in there and done an ulnar nerve decompression at the elbow. They've taken the nerve and they transposed it. We go in and we can't find it anywhere. We don't know where the heck the thing is. So the next thing we do is we make our incision bigger, go back to something where we know that ulnar nerve is in FDS or FCU, and we know that ulnar nerve has got to be approximately on the medial epicondyle, or we know that nerve has got to be its anatomy is normal somewhere. So go back to something you know, take a deep breath, think about what you know, start by saying something like flexor or medial, and then work your way out of that hole from there. Okay. I don't see that up here. Oh. It's weird. I don't see it on my screen. Nice. Man, she is so smart. Okay, flexors, where are they going to start? Medial epicondyle. Which nerve is going to innervate them? Median. What's the exception? FCU. See, start basic. PIN, wrong side. Median nerve, and FCU is going to be the. Okay, what are they going to do? Flex and extend, fingers and wrist, right? Flex the fingers. Oh, flex the thumb. Haven't gotten there yet. What is their name going to start with? So when we're in the Volar forum and I'm asking you questions and I ask you what muscle this is, always start with the word flexor. It's almost always going to be a good start. You cannot imagine how many times we have been there with very capable and smart residents, and I ask them a question, and we're in the Volar forum, and they start by saying extensor, and I'm just like, oh my God, I know you know better than that. Oh, this is where it starts to get cool. There are two layers of flexors, okay? What are the muscles in the most superficial layer? We just talked about this, so we should be able to rattle these off. Pronator teres, FDS, FCR, palmaris, FCU. Those are our superficial ones, right? That's all these guys. The reason we're going through this is because this is the topic, the title of this topic, or the title of this thing is surgical approaches, right? So there's always these superficial things. We got to get through these superficial things if we're going to get down into the deep stuff. Okay, so there they are there. No, so this is a smart one. It's a smart foot. I mean, this is coming from a guy who can fuse any joint in his extremity of choice. All right, what are the muscles in the deep layer? Yeah, FDS is pretty deep actually. Okay, even though even though it starts on the medial epicondyle, a lot of it is pretty deep. What else? It rhymes with thumb. flexor pollicis, right? Okay, those are deep. So there's FDS there. See how FDS is cool? It's all over here. It's a lot of it. It's got this big arch. This big arc right there. And there's a nerve that can get entrapped going through that arc. Yeah, well, that's a good one. So that's a good question for you guys. Here's your question for today. Figure out what nerve can get trapped in the arc, the arch of the FDS. Okay. So those are two in the deep layer. Okay, there's FDS. Then there's FDP. Well, we forgot FPL. FPL is here, right? And FPL muscle belly is really, really distal. So when we're operating on the wrist, we'll oftentimes see that FPL. When we do distal radius fractures, we see FPL all the time. So the muscle belly is way down there. So that's a good clue that you're looking at FPL when you see that muscle belly really distal there. Here's the rest of the deep ones. So FDP is really deep. Here's FPL, which is big, goes way deep. And then pronator quadratus is way down there. I love this picture here, it's cool. So here's our FDPs that are deep there. Here's FDS that's up here. Here's our superficial layers that's all gone. So through all of that. There's that right over here. That's FDS. That's the radial side of FDS, the radial head of FDS is there. So when we dissect in between these two muscles, we're really going in between FDS and palmaris. But there's a lot of the muscle belly of FDS that's proximal. What is this here coming across here? Flexor retinaculum, sort of. What do we call this? So this structure right here is the reason why people get bruising in their medial forearm when they rupture their distal biceps. What's that called? This band of fascia that goes across here. Travis, that's a good question for you. Why do people get bruising? Yes, the bicipital aponeurosis. Man, good job. You must be done driving and you're able to open up your Google.
I got that very wrong in the OR, and you made me feel stupid about it last year.
I don't think that's true. That's a straight up lie. Well, you probably just tried to BS your way out of it. That's fine. I didn't realize you actually felt stupid. That's great. I'm glad I had some sort of impression on you. You sure faked it well. I came out of that case actually thinking I didn't know what I was talking about. Travis BS his way so much, I was like, huh, I better go back and study this. He seems to know more than me. My son Mac and Travis have a lot in common. Is they just say things just so confidently that you must be right. That has got to be the answer. Dr. Elton, watch out. Okay. All median nerve innervated, right? Except one. Okay. Two branches of the median nerve. Two main branches. What are they? AN and, well, so this is more proximal. So Camille said palmar cutaneous branch of the median nerve, which is true, but that's a branch of truly a branch off of the median nerve. So proximally, there are two nerves, the median nerve branches into the median nerve proper, which is then going to branch into its various different distal branches, palmar cutaneous branch of the median nerve being one of them. And then what's the other one? That's distal, so proximally. AAN, right? So median nerve proper and AAN. And I should have a better picture of that, but I don't, and I need to put that one in there. So what are the muscles that are innervated by AAN? There's three of them. Right, so pronator quadratus, FDP to which two fingers? Index and long, right? We just say index and long. We don't say 1, 2, 3, 4, 5 because everyone always gets that confused. And FPL, right? So it's really deep flexors to the radial sided digits, right? And knowing that, the ulnar sided deep flexors are ulnar nerve innervated helps you to make diagnosis, right? Helps you to sort out where people's nerve injury is. Okay, can they flex their ring and small finger, but they can't flex their index finger and thumb. So when you're trying to sort something out, you gotta start thinking about that anatomy. So FPL, FDP, and pronator quadratus. How do we test for AIN function? Okay sign, right? So we saw a kid the other day who had an okay sign like this, which is indicative of somebody who's got FDS functioning, but they don't have FDP functioning. Does that make more sense now? Now that we saw that, you're probably not going to see this unless you're looking for it. And you always have to look for it in little kids who have elbow injuries, especially because that AIN is the most commonly injured nerve in those pediatric elbows because it's tethered, just gets stretched. That median nerve proper doesn't get injured very often, but the AIN gets injured a lot. Some people will say it's ulnar nerve, but it's probably not because I said it's AIN.
Or AIN palsies or PIN
The question is, do we see more AIN or PIN palsies clinically?
I've only ever seen PIN themselves. That's what.
Yeah, PIN you see in patients who have, humeral shaft fractures, radial nerve, PIN stuff. We don't see PIN very often. We look for it a lot, but we don't see it very often. We always are looking for it. So it's high on our list of on the differential diagnosis of when patients can't extend their thumb. FDP and FPL. Okay, so the question is pulp to pulp is FDS working because they're not. It's really just a lack of function of FDP. It's not got anything to do really with FDS, but it's indicative that FDP is not working and that FPL is not working. So here's those deep motor branches. Here's AIN coming off. Actually, this is a good picture of AIN, this next one. Yeah, I have a good picture. Never mind what I said. I have a great picture.
It's hard to see that mouse.
Oh, yeah, you showed me this the last time. There we go. Look at that. So here's median nerve coming down. Okay. And here's FDS. So this is that medial sided FD. No, this is that ulnar sided FDS section. And AIN is branching down off of here and then running down all through here. Deep in the forearm. It's innervating FPL on its way, which doesn't have you can't see that very well, but this is all going to be FPL here. Those are branches of AIN that are innervating that. And then coming down, and it's the last branch, it's innervating pronator quadratus down here. So median nerve proper, AIN. Here's median nerve branches to FDS, and AIN branches going to FPL, and then the last branch going down. And you can see based on where FPL is, why AIN is innervating it. Because it's deep, it's really deep. So here comes AIN down, it's hitting FDP. Okay. And then FPL is right there, so it's got to hit that. And then it just travels along the Volar forearm. And it does that pronator quadratus. So what, if anyone could give me the most distal function of AIN beyond pronator quadratus, you will earn serious bonus points. It's got one more function, distal to pronator quadratus. It's not a motor function. Nice. Volar wrist capsule, right? So it innervates volar wrist capsule. So sometimes we will do these denervation procedures where we're cutting AIN and PIN basically to try to relieve pain in the wrist. And you're cutting it very distal because it's innervating the volar and dorsal wrist capsule. It's probably responsible for some proprioception around the wrist in the volar capsule and the dorsal capsule, but people don't. There's plenty of innervation that does that. So it's not like when you cut that thing, people don't know where their hand is. So yeah, that's good. That's serious bonus points right there for Camille. So we've defined all the structures on the volar side of the wrist. So now we're going to go into our surgical anatomy. We're going into the forearm. Okay. What is the structure that defines the lateral border of the forearm? We're going to make an incision all the way up the forearm from the wrist to the elbow. What is the common border on that lateral side of the forearm that tells us what our interval is? So there's always an interval that we're going between two muscles, right? And what is the muscle? What is the lateral border that we're using as our guide to get us down into the forearm? It's an internervous plane that we're going between on the lateral side. It's not really dorsal side, it's lateral. It's the lateral volar forearm. So everyone point to your lateral volar forearm. Other volar. Lateral volar forearm. So what muscle is going to take us down there? What muscle is running right here? Brachioradialis, right? So that's it right there. So that's our key to getting into the volar forearm. It's always brachioradialis. And what nerve lies underneath brachioradialis? You always got to watch out for that nerve. It's running underneath brachioradialis. It's big. Sensory only. What's that? No, say it again. Don't start guessing. It is a branch of the radial nerve. What are the three branches of radial nerve? Radial nerve proper. Superficial sensory branch of radial nerve runs all underneath brachioradialis. Okay. So brachioradialis is our key to getting into the volar forearm. Interval, what is the interval proximally? It's going to be between brachioradialis and what? Between brachioradialis and what? Proximally. No? So we want to go right here. That's where we want to operate. I don't like operating right there, but that's where we're going to operate. Right where the dot is. What two muscles is that between? Pronator, right? Okay. And more distally, that interval is going to be between brachioradialis and what's this? Yep, FCR. And distally, it's a little bit of a trick, but proximally between pronator teres and brachioradialis, midsection between FCR and brachioradialis, and distally between brachioradialis and radial artery. This is the Volar approach, Volar-Henry approach. Okay. Did you guys read about the Volar-Henry approach to the forearm? No, it's in your book. God, this is terrible. All right. So here's what we're talking about right here. And a lot on this slide, but really what we're looking at is this interval right here, which is between, what muscle is this? Brachioradialis and pronator teres, and then it's right in here, which is between and Brachioradialis, and then down here, it's right in this area here, and that's basically radial artery. And brachioradialis. Brachioradialis inserts where? Radial styloid, and its function is if it inserts on the radial styloid, it can't move the wrist. Elbow flexion, right? Grace doesn't go across the wrist joint. Can't do this. Stops here. Right. Okay. Flexor's pretty easy. Now we're going to go to extensors. So we're still talking about the same part of the body. See how much repetition is here? This is not complicated, but if you go over it like 400 times, eventually you'll understand it. Okay. So we're ready to go to the extensors now. We're just basically surgical anatomy, dorsal forearm. Okay. 5 muscles that originate there. I'm not going to make us repeat these again, right? Anconeus, ECU, EDQ, EDC, ECRB. That's where we are here. There's that anconeus, mysterious muscle. Anyone know what function of anconeus is? Anybody on the phone know the function of anconeus? No, nobody really does because it's mysterious. It's it assists with basically locking out the elbow. So it's got a little bit of an extension moment on it, and it's got a little bit of a supination moment on it. So when you extend and lock out your elbow, that's where anconeus is most active. Doesn't do a whole lot. And that's why it's a good window for surgery. Let's get through that. Why do we approach the radius on the posterior side? What is that for? Typically. So proximally radial head or open reduction internal fixation of radial head. What else? How about to the radial shaft? Are we fixing radial shaft fractures through a dorsal approach? Not very commonly, unless they're really proximal. So proximal radial shaft fractures is one instance. Okay. So that's probably the number one thing, radial head or exposure to the radial shaft proximally. Some people will fix mid shaft radius through a dorsal approach, but not me, no way. Why not? Why do I say not me, no way? What is the danger associated with posterior approach to the radial shaft? Injury to what? Radial nerve. Where's the radial nerve end? Are we in radial nerve anymore here? So what nerve is down here? Not radial nerve anymore. PIN, right? So in ATC school, it's radial nerve. We're beyond that now. We are in PIN. Like this is that next level of detail. So it is a branch of the radial nerve, but it's not radial nerve. And if you say radial nerve, that'll be wrong. But PIN would be right. Or if you say the most distal motor branch of the radial nerve and you think to yourself for a second, and then you say PIN, that would also be right. So primary danger to that thing, or primary danger associated with all these approaches, PIN. That's why distally we're okay, because that PIN is doing most of its innervation in those muscle bellies proximally. So distally, that approach is pretty straightforward, and we're pretty aggressive in that approach down by the, mid forearm, because that innervation is coming off proximally. So we did this. What are the 3 main branches of radial nerve? PIN, superficial sensory, and radial nerve proper, right? Radial nerve proper, PIN, superficial sensory branch, radial nerve. Okay, here they are coming down. This is where we were talking about before. This is that crazy muscle, supinator, which is where that Radial nerve comes down and goes through supinator and does innervation for all these little guys. Okay. It's kind of what it looks like. What does it really look like? Okay. Now here's what it really looks like. Yeah, Jesus. Uh-huh. You see the similarity. Okay. So this is actually a guy who we took care of in South Carolina, who had annihilated his forearm. He blew his forearm off with a homemade cannon. Yeah. So had a homemade cannon that he would set off on 4th of July or New Year's Eve or like Wednesdays. And he basically blew his ulna into the night sky. So that all the shrapnel down here is all ulna, all along here. Now the red thing you can't see very well, but this is all his ulna, and his ulna is almost entirely gone. And we actually took this guy and created a one bone for him. He had his olecranon still. This is a olecranon there. And he had almost all of his radial shaft intact. We took his radial shaft and hooked it onto his ulna and gave him a one bone form. And his posterior osseous nerve, believe it or not, was working. But this is you couldn't do this dissection more intricately if you took hours and hours and hours to do it. But this guy did it in like 0.2 of a second with a cannonball. So yeah, that's what it really looks like. And that's why we're so nervous about that thing. Yeah, there you go. We'll just skip through that. All right. Can we name everything in these slides? Let's start. This is not that hard. This is review. And this is going to give us a sense for sort of our deep and superficial extensors of the forearm. Right? So let's start here. We don't need to do that. But what are these going to be? What are these guys here? Extensor indices, right? So here's our extensor indices. Now we'll work our way more proximal here. So this line is pointing to two structures, which are radial, inserting deep on the index and long metacarpals. What are those guys? ECRL and ECRB. Which one is more radial? L, always LB, from radial to ulnar. Okay, APL, EPB, ECRL, ECRB, radial to ulnar. Okay. So then what's this one? EPL, right? So now going more here, this one. This is a what is this guy here? Really distal muscle belly. And it's got extensor going up to the index finger. Distal muscle belly with extensor going to the index finger. There's two extensors going to the index finger, right? There's some very confused looks on the faces here. Yes, two extensors going to the index finger. And what are their names? The extensor indices and what is this? What is this one? What is this muscle? Yeah, EDC and EIP. Okay. EDC is the big one, and EIP is this one here. And it's a very distal muscle belly. That's how we identify it. It's a distal muscle belly in the forearm. It's one of the last ones. If somebody has a PIN palsy, it's one of the last muscles to recover because it's the most distal. Now we've got these two guys here. We're just working our way from distal to proximal. What are these two guys here? They're going over ECRL and ECRB. APL for sure. And there. What's the first dorsal compartment? EPB, APL, EPB, right? So we're working our way proximally. So there's APL, EPB. And when we have pathology right in that area, what does that lead to? What do we call that when there's pathology between ECRL, ECRB, and APL and EPB? Intersection syndrome, which we've actually seen on this rotation too. We did a surgery for intersection syndrome. We got to look right down at where these guys go cross over. And it was workman's comp, so she's never going to get better. But it was cool anatomy anyway. What do we got here? What's this little guy? Only ECU, we just got an ECU, but that's here. What's this little guy here? The funny one that starts way up on the lateral epicondyle, but goes all the way down to the finger. Where's it going? Yeah, close. Yeah, extensors minimi or EDQ. Yeah, that's the other name for it. Both of those are both correct. So now what do we got here? We already did this once. EDC. And now what's this over here? Most ulnar sided extensor. ECU. And how about here? These guys are going over and down. What is that guy? Look where it's going. It's going deep here underneath, going underneath these two, and it's going out here. So what's this muscle? Know it? No. APL, EPB are way distal right here, right? Yeah, those are way down there. This is proximal, off of the lateral epicondyle. Most radial sided one. There's the most ulnar sided one. What's the most radial sided one? ECR, L and B. L is superficial, B is deep, right? When that pathology is associated with ECRB, pathology is lateral epicondylitis, right? Okay, and what is this guy? Yep. And supracondylar ridge. So, okay, this is ECRB. I'm sorry, this is ECRB, and this is supracondylar ridge. So this is ECRL, and then this is going to be brachioradialis. It's hard because this kind of stuff is around the corner, right? And then there's just triceps here. This is a funny look at the forearm, but if you can sort through this, you actually know every single one of those answers, right? Just got to work your way back from stuff that you don't know towards stuff that you do know. And it's always easier to work from proximal to distal because then you're looking at where things are actually performing their function. Oof. That's a lot, but you got it. Oh, and here's deep now. So we just took off all those superficial ones. We've done all of these already, right? Except for these guys. These are all hand intrinsics, right? So what do we got here? That deep muscle belly we saw earlier. Okay, EIP. And then another deep muscle belly. What's that? It's this one here. You got it. Where's it going? EPL, right? That's extensor pollicis longus. Look at it. And then these two deep guys. First dorsal compartment, right? Which is Grace. What are these two? No, oh, those are extensor. Those are way up there. Done this already. These two, right? APL and EPB. See how these deep muscle bellies down in here. APL, EPB here. And then find that. Supinator going all the way around the corner of Sanancanias, proximally, mysterious muscles. So how do we get in there? This is it. This is what the approach looks like. And it's never, I mean, this looks kind of vague because everything is kind of shiny and it's hard to see the muscle bellies, but that's what this looks like. It's a tough approach. the approach up here is very difficult. You almost always want to start where you see these crossover tendons going out. So you're going basically between EDC and ECRL. So that's our approach. And there you see APL and EPB. And then you're right up in here. I'm going to get underneath that. We're going to find PIN. And if you guys get to see this approach, you'll be really lucky. Because we try not to do this very often. Because it's tiger country. I mean, you have to get in there and find this posterior osseous nerve. And the posterior osseous nerve does not take a joke. So you can mess around with that thing and touch it and squish on it and not cut it, and it still doesn't like it. So you gotta be careful. Median nerve, you can dance on that thing. Ulnar nerve it tolerates it okay. But the PIN, you even look at that thing wrong, and you'll have somebody have a PIN policy. Now you're down, there's supinator. ECRB. Now you're getting down to radial shaft. And what's this? Okay, so this is brachioradialis right here. That's brachioradialis, sort of superficial there. What are we seeing underneath brachioradialis? Superficial sensory branch radial nerve right underneath there. Okay. We're doing for time. Not really good. We have done this, okay? Done this like 9 times. Medial epicondyle, pronator teres, FCR, palmaris longus right down the center. Distal extension of palmaris longus is responsible for pathology associated with what disease, Camille? See it in my clinic all the time. The most distal extension of palmaris longus is responsible for pathology associated with which disease? Which disease process? Dupuytren's, nice, the volar palmar fascia. So palmaris longus extends into the volar palmar fascia. FDS, FCU, lateral epicondyle, Anconeus, ECU, in order now. Okay, can you do them in order now? You've got this. I just gave you the first one. Yep. Yep. You can say extensor digitorum, just follow it with the correct finger that it's extending. No. I'm raising my small finger.
Oh, it's the Q one.
Yeah.
EDQ.
Yeah, okay.
EDQ.
We're not sure if she actually knows what Q stands for, but
Is it,
quinti, yeah. Okay.
um,
I usually just say EDM, sensor digiti minimi. Oh, nice. Yeah, great, good. Boring. This is boring now. Inner nerves innervate these muscles. Median, 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 median. This is just seems rudimentary at this point, doesn't it? All right. That's good that it's starting to get simple.